All right, so I think we're going to get going. So we have as much of Carol's time today as we possibly can. I'm Rebecca Katz. I direct the Center for Global Health Science and Security here at Georgetown. And this is, we are delighted to have Carol here today. And this is part of we do a monthly seminar series. If you are interested in beyond today, we also, please let us know, sign up outside. And I believe our next event is November 17th, and Paul Reed will be here to talk about some issues on the border health issues. He's a pediatrician with the Public Health Service who's spent a lot of time treating patients in the detention centers. So with that, normally I would introduce our speaker, but today actually I'm going to introduce Julie Fisher, who is the director of the Elizbeth R. Griffin Program within the center, to introduce our speaker today. So here you go.
So in the spirit of nested introductions, I will actually keep this brief because I think that Reverend Russell gives her own eloquent introduction to why she is here. But I wanted to welcome the Reverend Carol Griffin Russell, whose name I just made. And
changed.
It's your first name, Michael, though. That's confusing. That's a lack of caffeine speaking. Before entering seminary, Reverend Russell practiced nursing for 35 years, including operating her own consulting firm to increase the efficiency of hospitals and compliance with regulations and other safety and other regulations. So she has a background in increasing the efficiency of healthcare systems as well as in clinical practice. Since entering the mission, she has worked in a variety of areas, and including working in global health as a mission through the Elizbeth R. Griffin Foundation. That work is what brought her here today, and what brought her to that mission and that work was a tragedy, the unfortunate and untimely death of Elizabeth Griffin, which is partly what Reverend Russell will be discussing today. But out of what was a tragedy and denial of a talented person to the world, through a series of mistakes and missteps by an institution that should have and could have done better, the Griffin family created the Elizbeth R. Griffin Foundation, which for 20 years helped promote biosafety, biosecurity, and finally global health security worldwide in low and middle income regions as well as at home by bringing scientific partners and professional associations into a discussion of what the evidence base is for preventing exposures to researchers and then responding if an exposure occurs. We at Georgetown have now benefited from not only being entrusted with carrying the Elizabeth R. Griffin Foundation's work forward in our program here at Georgetown, but being able to bring the leadership of that foundation for 20 years to Georgetown as affiliates and as experts within our center. So Jim Welch, who is sitting at the table, who I think many of you know, was the former executive director of the Griffin Foundation, and of course, Reverend Russell is here to speak to us today. So I'd like to thank you for coming up here, thank you for sharing your story, and thank you for trusting us with your story.
Thank you, Julie. Thank you so much. It's really a joy to be here. But I think the title of the story is wrong for an 8 o'clock in the morning seminar. I think it should be, why don't we wake up first? So this is about being woke, and I'll talk a little more about that in a minute. But this is how I feel about being at Georgetown. It's a delight for the Griffin Foundation to be entrusting you and to have your trust in us to be able to be here. I'm here because I'm Beth's mom. And so Beth was a 22-year-old researcher who had some struggles. She was a remarkable individual, but she suffered from a laboratory-acquired infection. The herpes B virus is the common word, but it's Cercospithecine herpes virus 1 or Macacine herpes virus. So at age 22, I looked on your website about Cura Personalis and was fascinated by what that means and what I see in the people here at Georgetown. And one of the things your website said to all of us is, you're more than a mind. You're an individual with unique talents, dreams, and passions. And that certainly describes Beth. So Beth graduated cum laude from Agnes Scott College with a double major in biology and psychology. She also danced in a dance company for 20 hours a week and won the dance award at Agnes Scott. She was a researcher and did 10 hours of paid research and presented at the National Science Foundation both her junior and senior years. She was very serious. And she wanted to know if she could really work with monkeys and do research for the rest of her life. And so she gave up being a paid dance captain in the 96 Olympics in order to volunteer at a primate center, to experience the work and to do some of the work in preparation for that. So this is the story of Beth and her personal struggle. It actually began day one on October 29th, 1997. However, I didn't know about it until 6:30 in the morning, 10 days later. I was commuting back and forth from seminary in the same institution. Beth was a researcher. And I was home, and Saturday morning, 6:30, the phone rang. And it was the call no mother wants to receive. She said, "Mom, I have matter oozing out of my right eye, and I'm really worried. I was splashed in the eye with monkey secretions 10 days ago." And interestingly, the day before when I was there with her, she was giving me a tour of the primate center. And first she took us to the B virus-free SBF compound where monkeys are taken away at birth to try to prevent contracting B virus. Because at that time, 85 to 90% of the monkeys carried B virus, and it was innocuous in a monkey, mucous membrane sores. But she said if it jumps species to the human, you could die within 2 weeks. So now she's calling me saying, it's been 10 days, and I'm really worried I have this disease. So we said, call your internist, a very prominent internist. She called her internist who said, well, it's Saturday, and I've never seen you before, and you need to go to the ER. She went to the ER, where she was diagnosed with pink eye and sent home, even though she said, I've been exposed. I'm not sure if I have B virus. I need to be checked. So just before she left, they gave her some eye drops and sent her home. She said, I need the number of the infectious disease office so that I can call Monday morning. And so they gave her a yellow sticky note with the number. Monday morning, 8 o'clock, she called the office. And they said, well, we have an appointment available in 2 months. And Beth said, no, I need to be seen now. And they said, well, you have to have a referral. So she hung up and called her internist again. And the internist again said, I've never seen you before. I can't make the referral. So she said, what am I to do? The internist said, well, I'll wait for your ER report and then decide. So 5 times that day, Beth called. Still no response. In the meantime, she's back at the center, and they say, well, you went to the ER, you need an incident report. So she completed an incident report and waited. Tuesday morning, she called again to her internist, who said, well, I have your ER report, and it says you got splashed in the eye. I'm going to send you to an ophthalmologist. So she went to the ophthalmologist, who said, well, I think you have cat scratch fever based on your history, and sent her blood to different labs unprotected, not to test for B virus, but to test for cat scratch fever, etc. Gave her doxycycline, which does nothing for a viral infection, and sent her home. Wednesday morning, she woke up with a pounding, relentless headache. So she called her internist, and her internist said, well, I've never seen you before. Call the doctor on call. At 9 p.m., the doctor called her and said, well, too bad you have a bad headache. And Beth was crying. She had intractable pain. She had made about 30 calls to different people trying to find help. And he said, well, you're seeing an ophthalmologist. Call him in the morning and then get seen by the ophthalmologist. So in the morning, overnight, she markedly worsened. She had nausea and vomiting. She had photosensitivity. She had nerve shooting, pounding pains. And so she called the ophthalmology office, and they said, well, we can see you at 3:30 this afternoon. And she said, I need to come now. And they said, well, we'll see you at 3:30. So I'm in seminary, and I come back at noon and get this crying answering machine message, help me. So I drive over to her apartment, find her very ill, call the ophthalmology office and say, we need to come now. And they said, okay. So I drove her over with a bucket in her lap and a blanket over her head and a lump in my throat. And we get there. She has to go in by wheelchair. They put her in this room with 2-story high windows with her photosensitivity. And every 10 minutes, I go to the desk and say, please, can you put us in a room? Finally, about 2:30, they take us to an empty hallway and put us in an exam room and close the door with the lights off. And we don't hear from them for an hour. Someone comes and gets her at 3:30, takes her to exam room. The ophthalmologist walks in, takes a look at her eyes and says, well, I don't see anything, and turned around on his heel to walk out. And I said, wait. And I had the yellow sticky note Beth had gotten from the ER, and I said, please call this number. And so he just grabbed the note out of my hand and turned on his heel and slammed the door. 30 minutes later, he came back, and he said, don't go through admitting, just go straight to 7th floor. There's a team of physicians waiting to treat you and to take care of you. So she goes by wheelchair up to 7th floor, where we're treated with, finally, someone will hear her and listen to her story and believe it. And they start all the testing that's appropriate, and they start the IV. Well, 2 days later, she's worse. So, and she can't be, the lights are off, she's in a dark room, she's throwing up. So they end up starting another IV, the IV with ganciclovir, a stronger antiviral, along with total parenteral nutrition, which is everything you need for your nutrition in a central line. That's how compromised she is. But within about 10 more days, she brightens up, she can stand the light, and the doctor says, you're a nurse, I can send you home, I'll send Beth home to your apartment, and you can take care of her. But she had this pain in her neck, and she thought she slept on her pillow crooked. So, 2 days later, on Monday, the doctor said, well, I'm ready to send you home. So she came to my apartment, and this pain kept getting worse. And I did everything in nursing that you can think to do to help relieve it palliatively, with ice, heat, massage, positioning, all these things. Nothing helped. And finally, at 5 a.m., she fell asleep. At 6, I started her IV through the central line. At 6:30, she needed to void. She needed to go to the bathroom. But when I tried to get her up, her legs were asleep. But we shuffled in and got her into the bathroom, but she couldn't void. And I knew, red flag, red flag, red flag. Called the internist, and he said, meet me immediately at the ER. Her older sister, our daughter Kimberly, had left her pediatric residency at St. Jude to come to help in the care of Beth. And she and I could together carry Beth to the car. So when she got to the hospital, she couldn't walk. She was admitted. By noon, she was paralyzed to the umbilicus. By 2 p.m., it was jumping up and affecting her respiratory muscles. So they said, we're going to have to intubate. So they decided to intubate her, and at 6 p.m. that day she was admitted. She was intubated. Also, they decided that this really wasn't B virus. They decided that it was an autoimmune post-viral process, like Guillain-Barré. It was acute, ascending, demyelinating encephalomyelitis. She was paralyzed at that time to the level of C4, just right at the top of her shoulders. She had about that much movement. And we had talked to her before she was intubated about Kimberly in pediatrics. Bill, my husband, then was a physician, and I had been a nurse, all with paralyzed patients, to talk to us by blinks, by first hand squeezes, but then we thought we better teach her blinks too. Thank goodness. So we did. And one blink was yes, and two blinks was no. And it was amazing how much she could communicate. And she was very alert despite her paralysis. By the next day, the paralysis jumped up to C2. She lost her swallow reflex. So the treatment was giving her massive doses of steroids, which is good if you have a post-viral autoimmune problem, taking out the white blood, mitigating that issue, but it's terrible for a viral infection. It's like throwing gasoline on a fire. The other thing they did was plasmapheresis for 5 days, each day taking out the white blood cells. Wasn't long before she really progressed and accelerated, and she had confusion, she had seizures, she had 108-degree fever, she had, of course, every nosocomial infection in the book, and so on. And finally, at day 42, 2 weeks after the second hospital admission, we had to take her off life support. But it was a devastating time. It felt like the sun was setting. And so we had to figure out what to do. And the first clue that something else was going on was when we couldn't get the death certificate for 2 months. And it's usually within a week. And we had to give Beth's card to her sister, and we didn't have the means to do that without the death certificate. Every week I called Vital Statistics. Where's the death certificate? Do you have it ready yet? Finally, I said, please help me. What do you think's going on? What can we do? And she said, we don't have the autopsy report. And then I remembered there was a person in the morgue who called me about Beth, and she had an autopsy. We donated her body to Julia Hilliard, the preeminent virologist, the world B virus expert, after Beth died. And Julia flew from San Antonio with her level 4 biosafety gear to do the autopsy. And this fellow said, if you have any problems, keep my number so you can call me. So I called him. And he said, I'll get back with you. He called the next day and said, I don't want to tell you this, but her autopsy report is locked in the lawyer's office, and it won't be released. And so we engaged help to get her death certificate and to figure out, that was our clue, to figure out what was going on. One of the things we learned from Julia Hilliard was that B virus is preventable. And so that made it even more important to figure out what was going on. Because you see, her death was a lightning strike. It was unusual. It had never happened at that university before. No one had ever had B virus. And so we wanted to look to the factors that can blind competent scientists and practitioners in an institution. This was an institution we all loved. My husband and I was in school there, and Beth was a researcher there. And the people were wonderful, well-trained, competent, compassionate, great reputations. What went wrong? And my thought was, if something so serious as this went wrong in this institution, it could happen anywhere. And how can we wake up to those factors and use them to potentially help other situations? Sometimes people were blind to risks and consequences. Sometimes the accidental death of a laboratory-acquired infection can shut down a lab because of loss of funding, loss of trust. And that did happen to another B virus case several years after Beth died, and this person didn't die. But because of the practices and the blindness, his lab was shut down. He lost his research of 30 years due to that. What we knew was the greatest tragedy was not Beth's death. The greater tragedy would be not learning and sharing the lessons that Beth's death teaches us. And so we had to become woke. And we decided to look for answers. Now, I looked up Webster's definition of woke, and it's interesting. It says, first of all, self-awareness. In other words, not blindness, or allowing yourself to see differently, questioning the dominant paradigm, and striving for something better. It's used as a word of action and calling others to become self-aware and active. It's about seeing with new eyes in a little different way than maybe we haven't been taught to think or see. So here are 10 life-saving learnings from Why Don't You? Yes, but in Beth's case. Because you see, that's what happens. When we called for after 2 months when we had to enlist an attorney, we started asking for the paperwork and different documentation. First thing we found was the incident report that was done after the ER experience on the next Monday. At the bottom, the principal investigator had written, no follow-up necessary. Secondly, we found that when Beth went to the ER doctor had done everything right and had immediately called infectious disease, who said, we've never had a case like that before. We've had lots of incidents. Nobody's gotten B virus. Low probability, no need to test. That was the same physician who was armed and ready on the 7th floor 5 days later, and I can only imagine his laundry bill after that. When he realized what had been going on. So, the first lesson is a culture of responsibility needs to be everywhere based on science, which I love this Global Health Center for Science and Security, Health Security. Based on science and successful experience. And I say successful because there were a number of cases of B virus. There were 3 laboratory outbreaks of B virus, one in Michigan, one in Pensacola, one in San Antonio, where there were several deaths from B virus, but there were also a couple of successes. So what happened in those successful cases? Those people weren't called on by our physician. And here was Julia Hilliard, the preeminent B virus virologist who does all the B virus testing in the United States, the only lab. And she had a great deal of experience with the titers and asked for a titer every single day from the physician, and she got 3 in 4 weeks. One was at the first admission, before the second discharge. When he sent that titer, Julia came in on a Friday, Julia came in on Saturday, took a look and called the physician immediately and said, you can't discharge her. She's in fulminating virus. You need to keep her. You need to change the drug. And there was a new experimental drug. It actually was in clinical trials for HIV patients a mile away from Beth in another hospital. And it was used very successfully. It's the drug that's used in every single HIV combination medicine today. And Julia even had it listed on her health directives to use for her if she contracted the virus. And she said, you need this drug. That physician carried the medicine in his pocket for a week, and it was never called on. And we were told by the physician that there was this new experimental drug that was very toxic, that kills the human cells in test tubes. We don't recommend you trying it. The right to try. So when you have a culture of responsibility based on science and successful experience, good things happen. You base your guidelines on risks, and the guidelines are followed. At this institution, 2 years before Beth died, there was a B virus working group who met to develop guidelines based on these laboratory outbreaks and failures and successes. Yes, but the physicians said, oh, we don't need to follow that here. We don't have cases of B virus. The second learning was occupational health needs to be specialized and becomes an advocate for staff and students. They were absent from Beth's case. So the occupational health needs to be trained in specific biological risks in each lab and area of the institution. They need to know what needs to happen, what are preventions, what are responses to incidents, serve on the IBC, the Institutional Biosafety Committee, and have input in proposals, research proposals, set those up ahead of time, etc., and then serve as advocates for the workers. It's not practical for physicians in an ER to be trained on B virus. How many times do you see it? How many times does the staff turn over? You can't do that. It has to be an advocate on any disease like that, from the institution to the ER. So, in 1970, OSHA produced an act that says people must be kept safe in their workplace. Now, it's interesting because immediately after Beth's incident, we started working with NIOSH, the National Institute of Safety and Health, and OSHA, who were investigating Beth's case. And what we discovered was there are specific guidelines for chemical, for radiation, and for, I'm blanking, what's the other one? The third. No. Chemical, radiation, and nuclear.
Oh.
Not biological. They didn't have specific regulations for biological. So we started advocating with them to develop it. How do we develop this system that can lead institutions to do the right thing? Third is all staff exposed to biological risks are comprehensively changed. Now, it's a no-brainer to train the people on the project that are in the lab. But what about undergrad students, visiting researchers, maintenance, and housekeeping staff? Some of those are not done, and Beth was not trained. She was trained some, but not all. So the rule of thumb is there needs to be training to all staff entering the area with biological risks. And one-on-one is okay, too, when you're coaching people. It's not about hope. It's about preparing. The fourth learning was personal protective equipment is available and utilized, especially with their lethal risks. And I want to note this, that often it is when a death occurs that people wake up. But the truth is you don't have to have a death to wake up. And that's what this talk is all about. That's what the foundation is all about. That's what the Global Center for Health and Security is all about. And it's monitored. It's modeled by PIs, and it's monitored. The culture in the institution where Beth was didn't wear goggles. Eye contamination was thought to be insignificant. You know, I didn't even tell you the circumstances of how Beth got splashed, did I? I forgot that. Okay, so what happened was that she worked in a compound of 100 monkeys, an open compound. And once a year, they came in for health checks. So they brought them in 6 at a time in a transport cage, and then 1 at a time went to a squeeze cage to be anesthetized so they could be safely handled and examined and so on. So this was 75 monkeys over the last 2 weeks had already been examined. This was the last of the day, last transport cage, the last monkey. and the monkey was scared and didn't want to get into the squeeze cage. So Beth knew these monkeys by name, by family, by very close to these monkeys. And she leaned down to coax this monkey into the squeeze cage when the monkey jumped and flicked his tail and splashed material into Beth's eye, secretions from the bottom of the cage that they'd carried many monkeys. She couldn't isolate which one might have had a problem. So she dabbed it with a paper towel, because the goggles were hanging by the door. Nobody was wearing goggles. And got brown material and said to the 15-year veterinarian tech leading the exam, shouldn't I wash my eye? Now, the eye wash stations are from me to Jim, away from her, doing the exam. And they said, no, we all get splashes in the eye. We need to take care of the monkey. No. The rule of thumb, as one CDC veterinarian said, is even in the middle of surgery, she said, this has happened to me, you stop. Somebody else cares for the monkey while you do your scrub. But it's modeled by the PAs, and it's monitored and enforced. So, I'm behind myself here. So, personal protective equipment is important. Goggles. Now, this one down the bottom is me going into my crawl space when I had to do some work, so it's not official. But the one here with the suit is a level 4 biosafety gear that was used on Beth's autopsy, and that's used in a level 4 lab. And, oh my goodness, what is that? That's supposed to be Rick. There's actually one of Rick in that dress. His personal protective equipment. You wear it. So the fifth learning is that there needs to be an immediate response policy, there needs to be the equipment, and it needs to be used in the event of an exposure. So the emergency cart is stocked and restocked as needed. Eye wash stations are available near the procedures, and the staff are trained and actually use them consistently. So the scrub, I'm going to learn how this works before we finish. So this is important. When you have an exposure to a virus, you have approximately a 5-minute window before the virus attaches itself to the cell membrane and begins penetration to activate the viral infection. So the rule of thumb is within 5 minutes, you must scrub. If it's a cut, a scratch, at some, whatever it is, or wash the eye within 5 minutes, and this exact number of minutes changes from one institution or another, and that's one of the scientific, there have been some studies, but how long do you have to wash? It's usually 15 to 20 minutes, sometimes even more than that. But within that 5-minute time, you need to do, this is an eye wash station. And by the way, after 45 minutes after Beth's splash, they finished with the monkey. As she was walking back to the ladies' room to change out, she was saying, I got brown material in my eye. I need to wash my eye. So Rosie, the housekeeper, helped her stick her head under the sink in the ladies' room to rinse her eye. A little too late. So 6 is comprehensive incident reporting system is in place and consistently utilized and revised. And let me say, not just incidents, but near misses. Data is reviewed and policies are revised in response to training is updated. Yes, but that's a lot of trouble. And if it's just deemed insignificant, why do you do it? But oftentimes, that's what really helps you know what gaps there might be and where you need to look for answers and changing things. The 7th learning is medical expertise is available to evaluate, to diagnose, and to treat incidents immediately. The personal physician knows your risks. Does your personal physician know if you are exposed to any risks, what you might be working with. That's a question. The occupational health system is your advocate. And specialized, knowledgeable MD is consulted, or PhD, like in the case of Julia Hilliard with B-Virus World Expert. They're available to identify and to deal with the diseases. So the question is, does your primary physician know what you do and your risk? Is OC Health available? Yes, but this is insignificant. And she went to the ER. What else can you do? The eighth learning is that medical prevention and response plan for incidents is operational. So that piece is starting at the IBC, the Institutional Biosafety Committee, is for vaccinations, if you need, for the work you're doing, if there's one available for the pathogens, job placement. Some people shouldn't be working in a particular area if they have allergies to rodents or there are other issues. If they're immune compromised, sometimes they don't need to be working in specific areas. Prophylaxis response is outlined and utilized. In the case of B-Virus, the rule of thumb is administer acyclovir within 24 hours to stop the viral replication. There was a needle stick injury in Florida that was negative on baseline. 2 weeks later, the person was negative for B-Virus with the eye swabs and so on. And but one physician said, but the monkey had seroconverted. That was the clue that you need to look further. The monkey was negative in the beginning, but then seroconverted to B-Virus, active B-Virus. So some smart person decided to do a punch biopsy of the healed needle stick site and found B-Virus. But she had been administered acyclovir within 24 hours and did not continue the replication of the virus. And 25, 30 or more people who are living survivors of B-Virus have still take antivirals 20, 30, 40 years later. So prophylaxis is given for B-Virus, the antivirals, the Virax, one of the least toxic drugs we have on the market today, within 24 hours. But if you're doing CRISPR research and it's DNA and you're rearranging DNA and you get stuck and you don't have the same issues your potential material is trying to correct, what's it going to do to you? It changes your DNA. So the occupational health, one of our forums that we did, came up with this from people around the country. Pills on the tummy within 2 hours. Stop DNA replication in your body because it's passed on to your children. There are some issues that need to be continued to push the envelope to find out what to do. Ninth, in a laboratory-acquired infection, one of the studies said that the deaths from laboratory-acquired infections are often due to the fact that since most diseases present as flu-like symptoms, the diagnosis is delayed and delayed and delayed until the person becomes so bad, it's then untreatable. So rule out lethal and lab-specific diseases immediately. In medicine, here in the United States, all medical schools teach in diagnostic classes, treat for the most common disease first. But when you are exposed to lethal material and you work in a lab with the risks, you rule out the zebras first. Now, this was a problem when we started training in Africa. They have so many zebras, you know. So I said, well, what do I say? What do you do? What does your medical school teach? And she said, well, we just learned that what's common is most common. Start there. So you think the zebras first, not horses. 10th, and the phrase is, when you hear hoofbeats, think horses. Think horses, not zebras. So 10th is consult with knowledgeable MDs and PhDs, experts with experience, science-based practices. So draw from the science, the innovations, the right to try treatments, listen to experts with the previous disease experience and success. There you have it. And so Julia Hilliard would be one of those. Dr. Dave Davenport was an MD in Michigan, had successful treatment of B virus people. Did you know him? No. So here's a spoiler alert. Spoiler alert. Standing on science and experience helps prevent institutional holes, buttholes. That wasn't very ministerial. So after the lightning strike, and we started working on it, people started asking us for help, and I was in the seminary, and Beth's colleagues were in the building next to me, and they would come and find me and say, help us, nothing's changing here. No new things are happening. New employees aren't told about Beth. Help us. What can we do here? And other places started asking. And we realized that we had a duty of care, and that any institution with a biological risk associated with it has a duty of care for the people who work there, for the patients, for the community, and even for the world. This is my husband, Bill. Beth is petting a horse. She had that care, I'm telling you. And then, and we both realized we needed to. But one of the most major influences on my life was Archbishop Tutu. I took classes with him for 2 years. And my Truth and Reconciliation project was Beth's situation with the institution. We did not want litigation, anything like that. We just wanted change. I'd been a change agent for 10 years. My whole operations were about making things work better and effectively. And so this was important to me and to our family. So this is our family. This is not long before Beth died. We were on a bike trip in Ireland. So we began the Elizbeth R. Griffin Foundation and have had now 20 years. It's been 22 years since Beth's death, so 21 years of progressive advocacy. And it's about Cura, Personalis. It's about looking at the whole picture, the mind, the body, the spirit, the whole person being involved in what needs to happen to make things better. This is Beth in her working outfit, examining the monkeys. And for us, it was more than hoping and more than training. It was about being woke, and our goal was no further Beth Griffin tragedies. So how do we begin? We started partnering with people, with the Association for Primate Veterinarians. That's where it began. And then with the American Society of Biosafety Association, which is now international. Multiple disciplines. And so we began, first of all, contacting the 650 plus research labs in the United States and advocating and sending posters. We had 50 reasons for safe specs, and that was all kinds of things like playing ball with my son, or having a date with my wife, or going to a birthday party with my mother, and Jim, you may be able to add some of those. And laboratories started having contests about what would our top reasons be for practicing safe specs. Then Canada called and said, we want you to work in our area too. And we began to work with professional organizations and labs in Canada. Then after 9/11 and the anthrax letters, Level 3 labs started springing up in sub-Saharan Africa and the Asian Pacific, and staff were not trained, and this was an emergency. And so they asked the Griffin Foundation to be involved to help develop the training and leadership in these areas. Sub-Saharan Africa, the highest infectious disease burden in the world, and Asian Pacific, where the bird flu, both of these diseases emerge where nomadic tribes encroach on wild animal lives, and the diseases jump to the livestock and then jump to the people. Then we had an interesting thing happen. There were professionals that we were working with, specialized people, the subject matter experts, who said, you know, at my institution, we're doing some really good things, but I have this greater vision. We could do so much more if we could just have a way to be able to do that. So several of the professionals got together and formed the BEAMS team, and that's the Biorisk Engagement and Management Solutions team, where they envisioned and began some amazing things worldwide that they still stayed with their institutions, but they could provide special projects throughout the world. And in the last year before we joined Georgetown, we had over $1 million in grants, $1 million in grants for these projects that the BEAMS team wrote and enacted. During this time, part of the BEAMS team effort was the Ebola, and after the 3 countries that were so hard hit, there was a person who came from Liberia, maybe, or Sierra Leone, I'm not sure, and came to Nigeria. And they were alarmed because this is a huge metropolitan center. So they called the Griffin Foundation and said, can you come help us do a whole of community approach to deal? We don't want the same scenario these other countries have faced. And so we came with a team of 6 interdisciplinary people to work with Doctors Without Borders, World Health Organization, CDC, Hospitals for Humanity, and did a comprehensive plan. And the goal was to arrest Ebola in its spot. But every person needed to be woke. I want you to hear this because this is true whether you're at Georgetown or NIH or USAMRIID or any other corporation or hospital. It sometimes takes the whole of the community to be woke, to deal with it. And so during this time, this is a shot from Nigeria. In a week's time, these people trained over 800 people in Nigeria. Some intensively in small groups, some in larger groups. It was police, ambulance, religious people, hospital people, the staff they had to prepare. They opened an ICU the next day they were there. But what happened was their personal protective gear wasn't released from customs right away. So they had to go to the equivalent of Walmart to buy plastic and rubber boots and raincoats and all the things to try to fashion. And there was one in particular incident, and they had to wear the level 4 gear. And there was one instance where the first day in ICU, and the nurse was recruited to come and agreed to do it. And the patient was admitted then and just, she was totally contaminated and had deer in headlights terror in her eyes. And in the other countries, people left for that, and they didn't come back. But the leader, Gavin McGregor, went over to her and just embraced her and whispered in her ear and said, now I'm contaminated too. We're in this together, and we can do this. And she had a whole different attitude. There was a calmness then. We can handle this. There was the buddy system, and there's some watching out for each other. But people were engaged all over the country, and part of the training included corporations like the telephone company. And so any contact, and there were about 300 just from this one patient, were given thermometers and phones. And the telephone company said, I'll tell you what, we'll give 30 minutes free airtime for people who comply. And they got great compliance. But then what do you do after a week? You just don't dump and run. So he set up a longer-term plan with a consortium of 14 universities and video satelliting. And it was to train not just nursing and medicine and so on. It was to train every person in that university down, even including housekeeping and maintenance and anybody you might not think would need it, but they needed it. And they were charged with going back to their communities and teaching how to wash their hands, what to look for in Ebola, what to do if you think you might be having a symptom, etc. It was the whole of community approach. So Jim had this amazing vision, working with the American Biological Safety Association, to start biological safety associations in countries all over the world. So when people came to the United States to the meetings, he looked for people with shiny eyes. And then he said, you can do this. Because you see, the rule of thumb is it has to be local, it has to be practical, and it has to be sustainable. And the only way you can do that is not train and dump and run. It's to engage the local people and be a part of it. So that means in any institution the same way. In corporation, you have to have the local leadership involved in creating what happens. And so Jim had so many of these things going that then they decided to become International Federation of Biosafety Associations, and it's still going today. And there's a tremendous networking and sharing and building of networks and professional knowledge and teaching. And then we were invited to the White House briefing on the global health security agenda rollout. And the rest is history. We met Georgetown and actually, this is Julie, at that one particular meeting, but many people you know there. And it's all because of the work that Jim has done. He was brilliant in establishing partnerships. Because you see, the Griffin Foundation only had one paid full-time employee in the 20 years. Until the Beams project, and then we had a part-time accountant. That's it. So all of our work, all of our influence happened through partnerships. And people brought their resources to the table. It's like the stone soup story. And so that's an important piece. And we had over 100 partnerships, and you'll notice Georgetown University is certainly one of those. And these are who help create the vision and the way forward. It's the intersection of policy and intervention that happened, and that brought us together with Georgetown, who so graciously, Rebecca and Julie, invited us to come and to consider. We were looking at several different places to consider here. And we thought it was a really good fit. It's a combination of the hands-on provider and the leadership development and the development of national policy, and we both were running into each other all over the world, and it just seemed like a really nice match. And in the words of Julie Fisher at her address at the American Biological Safety Association last year, every index case is a daughter, a son, a sister, a brother, a mother, a father, a person. A real person. And every incident is at least a sleepless night. Most lessons are learned the hard way, but we're here to tell you don't have to learn the hard way. Don't wait for a death to decide you can do something differently. And we only learn and act when we believe. Great things to base your work on. It's a matter of being woke. These are a few pictures of Beth doing all these different things. So now, you are the keeper of the story. So, what is the power in the story? Where is the wake-up call? Now, I'm going to ask Alexander and Julie to give you each a special memento of today and a best story. These are carabiners that say safer together, and they represent your life and how you can connect with other people to create a safety net. It's about duty of care and developing a culture of responsibility within your arena, no matter what that is. It could even be not just work, but at home or in your community. And so this carabiner is your particular piece to remember. I have it everywhere. I have it on my suitcase. I have it on my purse. I have my keys on it that I clip to my belt. It's for you to wake up and remember. And so I want you to stop for just a minute and hold your carabiner and just relax for just a minute. Lean back and just allow yourself a breath. And I want to ask a few questions. Just think about this. How can Beth's story make a difference in your work or your life? Was there anything in her story that connected with you? Or that you thought, I did that. Or, I know somebody who had that? How can it make a difference to you? What do you need to pay attention to more wisely? Is there something around you or in your work? What experience with accidents or near misses have you had? Or someone close to you? A needle stick. I've been stuck by a needle, and I mean, you don't want to do an incident report on it. It's just a little stick. It doesn't hurt. It's just, a prick. What experience have you had? Where does science and experience need further investigation? What do we need to explore further to really know what to base things on and what to do? How might your stories be used toward the safety and security of future generations? What are you going to leave for someone else? Who can benefit from some of your experiences and thinking and the science you're writing right now? Some of you are writing articles and all kinds of things. What might you contribute to GU, to your organization, to the world? What's your vision? What's your dream? Where's your Beam's dream team? Do you have one? What can you do beyond? So, I've told you the first part of the story, but the rest of the story is in your hands. And now through new, shiny eyes, being mindful in a new way. We're just taking baby steps, but we start where we are. Amen.
Thank you so much for sharing.
Oh, you're welcome.
Powerful story.
Thank you, Sarah. It's hard to share stories. It's hard to be vulnerable, and institutions don't like that. But to have that professional courtesy, it's a professional courtesy, and it takes a lot of courage for an institution to do that.
Let me also thank you for that, for sharing what I know it must be hard to do that. But I'm impressed not only with what you learned, but how you learned from it. I mean, I can imagine what Bishop Tutu's
Yes.
approach that you took to learn rather than to blame.
Yes.
And the question is, how can we encourage others to do that in actions that happen in the future?
Yes.
And is that something that the group is doing, or?
Yeah. Oh, that's what we do all the time. That's.
I'm not to prevent it.
Oh, yeah. No.
But to learn from actions that do happen despite the effort.
We do have meetings, and we have a colloquium every year on occupational health, and invite. It's a small group, 100, so that we limit it to 100, so that people can share vulnerably, and so that we can build on experiences in science. Some of the best people are there, and it was in Alexandria last year. Julie is now spearheading that with Eagleson Institute. But it's encouraging. It's like today, encouraging people to let down their guard, to drop their egos for a minute, to be able to rise above the pain. I mean, this is what kept happening to me. I was in seminary, and I was being preached to, forgiveness, grace, and Lord, my daughter died, What do we do with that? But it's about rising above the pain to be able to do what's right for the common good, for the greater good. And I know that's the spirit here.
So I don't know. I'm glad I'm a veterinarian here at Georgetown, and will just attest to the fact that Beth's tragedy and the work that this foundation has done has had an unbelievable impact on how primates are now handled in research facilities. Unbelievable. All the steps that Carol laid out there are pretty much standard procedure now. But it wouldn't have happened, I don't think. The way you had approached this and the work that you did with Cura. So every day, me, my staff, the researchers here benefit from the work you've done, and that's amplified across the country. So I'm, personally thank you for what you've done. But there's no doubt that they made, just with herpes B alone, not even approaching everything else that your foundations, but the impact.
Well, the truth is you can invite, but you can't coerce. And we couldn't do anything locally after Best Splash. The institution had to heal. They had to, for a time, find their own way. But they were peripheral and saw what was happening and working with other labs. But they came to be major players with us. And the head of their environmental safety and health, who was brought in for her expertise to change not just the biosafety, but the whole institution, became our global leader, our global manager in the Beams project. And so everything changed in the institution, and it changed the staff, changed the heads of departments, changed the president, changed. There was an entire culture change in the institution where Beth worked. But it's hard. It's really, really hard. And sometimes it takes time. It takes time. It's embarrassing, humiliating. And there's a fear that you're going to lose your standing, where the truth is the opposite. If you own it and do something about it and become a leader in making the change, how powerful that becomes.
I think we need to find a way to reward the people who do that kind of, take that kind of work.
That's a good, Steve. Yeah. It's great. Well, thank you all for being here, for taking your time, and for being in this space. It's wonderful.